Good afternoon. My name is Josiah Muruve. Today I will be presenting a case of severe preeclampsia, which was managed in our facility here in Longido District Hospital, which is located in the Longido District Council in Arusha region, Tanzania. And our presentation will cover the following areas: patient background, present complaint, pathogenesis, clinical manifestation, investigation, treatment, complications, and outcome and the discussions. So let's start with the patient's background. So this patient named Natemuta Lodo, she is having 20 years old, and she's gravida 1 para 0, and she was admitted with a gestation age of 37 weeks. The occupation of this patient is a farmer and animal keeper, and she resides here in Longido. So during admission, the patient presented with the following complaints. So the patient presented with a severe headache for about 2 days, blurred vision, swelling of the feet, meaning the swelling of the lower limbs, and also she was complaining of the epigastric pain, and all these have been existing for more than 1 month. So the patient didn't seek any medical attention, and she was well before that until she started experiencing this complication. And prior to admission, she was well, and she said that she developed a severe headache associated with a blurred vision and swelling of the lower limbs. She sought care at the nearby health center, which is called Encarenaibo. And when she arrived there, they opted to refer her to the higher level facility, which is Longido District Hospital, with the main complaint of elevated blood pressure, lower limb edema, severe headache, and the epigastric pain. So in short, this is the history of the present illness of our patients. So after she arrived here in Longido District Hospital, we conduct a physical examination, whereby on general examination, the patient was conscious, she was alert, and there was a pedal edema. On vital sign, the blood pressure was 1/7 of 100 mm of mercury, pulse rate was 92, the temperature was 36.8 degrees of Celsius. On obstetric examination, the fundal weight was 37 centimeter, fetal rate were 142 beats per minute. After physical examination, we conducted the investigation. So in case of a severe preeclampsia, investigation are performed to confirm the diagnosis, assess disease severity, to identify organ involvement, detect complication, and guide the management decisions. The first investigation we conduct is urinalysis, and the findings was our patient present with a proteinuria plus. So why urinalysis was performed, it is done to detect the presence and amount of protein in the urine. And in preeclampsia, as we know, there is a damage of glomerular endothelium in the kidneys. So this damage increased permeability of glomerular membrane, allowing protein, especially albumin, to leak into the so this proteinuria plus, it indicated that there is a significant renal involvement, there is increased severity of preeclampsia, and it confirms one of the diagnosis criteria of preeclampsia when associated with hypertension. The clinical importance of this investigation, first, it helped to confirm diagnosis. Also, it helped to assess the disease severity and to monitor the progression of kidney damage. The second investigation which you conducted was a full blood count, and the first one was hemoglobin. We assessed hemoglobin so as to test the anemia and the hemo concentration. So what does this have a significance in case of a preeclampsia? In preeclampsia, due to increased capillary permeability, plasma tend to leak into tissue, causing hemoconcentration. So as a result, hemoglobin may appear elevated due to reduced plasma volume, and alternatively, anemia may occur if there is no hemolysis, as example in HELP syndrome. The clinical importance of this, it helps to assess maternal conditions, severity of disease, and presence of also on full blood count. We also assess the platelet count. Why do we assess this? Is because we want to detect the thrombocytopenia or its low platelets. And the significance of this in preeclampsia, it shows the endothelial damage activated the clotting system. So this will lead to platelet consumption and formation of microthrombi. And automatically, this will lead to platelet count fall. And the clinical importance of this, actually we know that the platelet, when the patient is presenting with the low platelets, it may indicate that the patient is having severe preeclampsia or is having HELP syndrome, and the patient is at risk of bleeding during pregnancy. And when we find that a patient presents with a platelet count below 100,000 millimeters of mercury, we consider it a severe feature of a preeclampsia. Another test which we conduct is a liver function test. We call it LFTs. And the finding here, we get the patient present with elevated liver enzymes. And why do we perform this liver function test? Is to assess the liver, the functionality of liver. So the significance of this function of this test in preeclampsia, usually we know when the vasospasm and reduced blood flow cause liver ischemia and hepatocellular injury. Also, we know that it causes damage in liver cell, release enzyme into the blood streams. The clinical importance of this, when elevated liver enzymes, we find them in the blood, it indicates hepatic involvement. It also indicates severe preeclampsia, and it also indicates the possible HELP syndrome. And the patient may present with epigastric pain or right upper quadrant pain. So these symptoms are very, very important and are the warning sign for a patient who is presenting with a severe preeclampsia. Another test is the renal function test. Here we test urea. So why do we test urea? Because you want to assess the kidney function. So the significance of this in preeclampsia, the reduced renal blood flow decreased filtration of waste products. So as the kidney function worsen, the blood urea level rise. So the clinical importance of this, the elevated urea, it's when we find that the urea is elevated, it suggests that the patient is having renal impairment or the patient is having severe disease progression. Another test is creatinine. Why do we perform this? We perform this creatinine is actually is one of the tests to assess the functionality of kidney. When we perform for the patient who are having preeclampsia, usually want to see the glomerular damage reduced due to the kidney ability to filter creatinine. So when there is a glomerular damage, automatically we'll find the serum creatinine will increase. So when the elevated creatinine, when the creatinine are elevated, it indicates that there is a reduced glomerular filtration rate. There is a significant renal involvement, and it also indicates the patient is having severe preeclampsia. So after that, I would like to talk about the pathogenesis of this condition. Preeclampsia is a multicellular disorder characterized by hypertension and proteinuria after 20 weeks of gestations. Yeah, as I've said, preeclampsia is a pregnancy-specific multi-system disorder which is characterized first by elevated blood pressure of equal or above 140/90 millimeter of mercury, and this should be after 20 weeks of gestation. Also, if the patient presents with a proteinuria plus, we can conclude that the patient is having preeclampsia. So it usually results from abnormal placental development and maternal endothelial dysfunction. And generally, we can say that the exact cause of preeclampsia is not fully understood, but the pathogenesis occur in two major stages, as I'm going to explain. The first one, or the first stage, is abnormal placental development, which we call it a placental stage. And the second one is the maternal syndrome, which we call it a systemic disease stage. So to begin with the abnormal placenta development or placental stage, first we have to understand the normal placental development during early pregnancy, which we usually focus during the 8th up to 18th week. The first stage is a trophoblast inversion. So the trophoblast cell from the embryo invade the maternal uterine wall and remodel the spinal arteries. The normal spiral arteries are narrow, muscular, highly resistant vessels, and the trophoblast convert them into wide, thin-walled, low-resistant vessel. So this allow increased blood flow to the placenta, and this lead to adequate oxygen delivery and nutrient supply. But in this case of severe preeclampsia, as we have said, there is an abnormal placentation there is an abnormal placentation of the placenta. So in preeclampsia, we have the defective trophoblastic inversion. So the trophoblast fail to invert deeply into the maternal spiral arteries. So this leads to the spiral arteries remain narrow, they retain their muscular walls, they remain high resistant vessels. And due to this, we found that we end up with decreased uteroplacental blood flow, decreased reduced oxygen supply, and automatically this will lead to placental ischemia and hypoxia. So this is the initiating event in a pre-eclampsia. So let us look at this stage. In the first stage, we have a placental ischemia. Because blood flow is reduced, the placental hypoxia develop. So the placenta receive insufficient oxygen. The ischemic placenta becomes stressed and begin releasing harmful substances into the maternal circulation. These include the anti-angiogenetic factors. So these substances are the central to the development of a pre-eclampsia. Let us go deeper to look about these anti-angiogenic factors. So normally the body produces VEGF, which is a vascular endothelial growth factor, and the PIGF, which is a placental growth factor. So these maintain healthy blood vessels and the endothelial functions. So in preeclampsia, you find these anti-angiogenic factors, which I've mentioned, they tend to bind and neutralized. So as a result, we end up with a decreased vascular endothelial growth factor. We end up with decreased placental growth factors. So this will end up in endothelial damage and the widespread vascular dysfunction. On stage number 2, it is a maternal endothelial dysfunction. So this is the stage where the clinical symptoms appear. The maternal vascular endothelium became damaged. The endothelium in the inner lining of the blood vessel also they become damaged. So when they damaged, we have three major effects occur. First is vasoconstriction. Second one is increased vascular permeability and activation of coagulation. So on vasoconstriction, when the endothelial damage occur, it causes increased endothelin, which is a vasoconstrictor, and decreased nitric oxide, which is a vasodilator, which automatically lead to decreased generalized vasospasm and increased peripheral resistance and hypertension. So this explains the hallmark of the finding. When you test this patient blood pressure, they end up with a high blood pressure. Another issue is increased capillary permeability. So you find this damage in the endothelial cell became leaky. So fluid escaped from the blood vessels into the tissue, which lead to edema. And usually this edema is manifested by swollen feet, swollen hand, and facial edema. And hemoconcentration. The blood become more concentrated because plasma leak out of it. The third one is activation of coagulation. After that, the endothelial injury usually activate platelets. So when these platelets are activated, they cause platelet aggression and microthrombi formation. So small blood clots from coagulation. So these are the small blood clots. They form throughout the circulation. So they end up in thrombocytopenia, organ ischemia, and the HELP syndrome. So after all this damage have occurred, the effect on a specific organ, what are the effect on a very specific organ happen after all this damage has occurred? First, let us look at the kidney. So the kidney are the one of the most affected organs. First one, because let us look at the glomerular endotheliosis. So the glomerular endothelial cells tend to swell and end up in reduced filtration, protein leaking to urine, and they lead to proteinuria. So this is one of the diagnostic criteria of a preeclampsia. So when these kidneys have been damaged, they also cause reduced kidney perfusion, which cause oliguria, acute kidney injury. On the other part, another organ which is affected is the brain. This causes cerebral vasospasm and edema develop. The consequences could be headache due to reduced cerebral blood flow, visual disturbance. Example, the patient can present with a blurred vision, scotomata, and temporary blindness. Also, the patient can present with seizures. This is especially when there's severe cerebral irritations occur to this client. Another organ which can be damaged is the liver. This can cause a reduced hepatic blood flow, which can lead to liver ischemia, and the patient can present with a symptom like a right upper quadrant pain, epigastric pain. And when we perform liver function test, we can get the finding like elevated liver enzyme. Also, the patient, if the condition is worsened, the patient can present with a HELP syndrome. And the first H stands for hemolysis, EL stands for elevated liver enzyme, LP stands for low platelet. Another organ which can be damaged is placenta. The patient can end up with a placenta ischemia and with poison further. When the placenta is affected, the patient can end up with intrauterine growth restriction because the baby will receive low oxygen and less nutrients. Also, the baby can end up with a fetal distress because for poor placenta perfusion can lead to hypoxia and acidosis. Also, we can have a placenta rupture, which is the premature separation of the placenta before term. This can cause severe bleeding, fetal death, and the maternal death. Another organ which can be affected are lungs. This is because of increased vascular permeability, which causes pulmonary edema. Fluid can tend to accumulate in the lungs, and the patient can present with the symptoms like shortness of breath and hypoxia. So in short, the pathogenesis of this disease, we can say that the key event in preeclampsia is abnormal trophoblastic inversion of the spiral arteries, which lead to placental ischemia. So this ischemia, the ischemic placenta release the anti-angiogenic factors that cause a widespread maternal endothelial dysfunction, result in vasoconstriction, hypertension, proteinuria, edema, and multi-organ damage. On a clinical manifestation, here we are going to explain some of the issues that this patient will present with. So a patient can present with some symptoms like a severe headache, blood vision, epigastric pain, and swelling. And the others can be, the sign can be hypertension, proteinuria, and the hyperreflexia. So as we have already explained on the pathophysiology, so the patient can present with these clinical manifestation. On management of a patient who is presenting with a severe preeclampsia, usually we aim at first controlling the blood pressure. Second, we have to focus on avoiding or to control the seizures. So on managing the blood pressure, we use the nifedipine tablets together with methyl dopa. And on managing or controlling the seizures, usually we use the magnesium sulfate, which is 14 grams. Magnesium sulfate is the drug of choice for management of a patient who is presenting with eclampsia with severe features, or the patient who has already developed the eclampsia. But otherwise, the definitive treatment of a patient with severe preeclampsia is the delivery of placenta and the baby. Why do we focus, or why do we say this is a definitive management of a patient who is presenting with eclampsia? Because according to the pathophysiology, we have seen that what causes the patient to present with eclampsia, it develops from the placenta. That's why we say the definitive treatment or the definitive management of a patient who is having preeclampsia is the delivery of the baby and the placenta. So for this patient, our patient was admitted here at the hospital, and after she received the initial management, she was kept on magnesium sulfate 14 grams as a loading dose and maintenance dose. She was also planned for cesarean section. We conducted cesarean section and delivered a male baby with 2.7 kilogram. The baby scored 8 in the first minute and 10 during the 5th minute. So both mother and baby are doing fine. So the mother will continue receiving the maintenance dose while she, for the time being, she is here with us at the hospital. So according to this case, actually we insist the client who are attending at clinic first to book early, to start attending antenatal clinic early, in order to diagnose if the client is having signs of severe preeclampsia. And also we encourage the facilities to conduct the lab investigation, taking the blood pressures regularly, so as to make sure that these clients are monitored effectively. And as we say, that early recognition and time management of severe preeclampsia are critical in preventing maternal and fetal morbidity and mortality. Thank you.